Welcome to another deep dive. We're tackling a really specific high-yield topic today, pulling directly from some excellent revision material. Think of this as distilling those essential facts into a focused audio session, kind of perfect for solidifying knowledge for something like the MSRA exam. We're diving into port wine stains. Our goal is simple. Just cut through the noise and get straight to the crucial stuff you need to know about these birthmarks. You know, what they are, why they happen, what they look like, and critically, what they might be associated with and how they're managed. It's really about making sure the key points stick.
Exactly. Port wine stains, or capillary malformations, as they're also known, are a classic topic. They definitely come up in clinical practice and, well, certainly in exams. Getting a clear handle on the core concepts is key.
Okay, so let's jump right in then. At the most basic level, what is a port wine stain?
Okay, so at their core, these are congenital vascular birthmarks.
Congenital, so present at birth.
Yes, present at birth, and they involve blood vessels, hence vascular. They appear as flat patches on the skin, ranging in color from pink to, well, quite dark red or even purple. The fundamental issue is an abnormal development of the tiny blood vessels, the capillaries, in that specific area of skin.
Right. And you mentioned present at birth and vascular. What about their permanence? That seems like a really key feature that distinguishes them, doesn't it?
Absolutely, that's crucial. Unlike some other common birthmarks, maybe like infantile hemangiomas, which often shrink away.
Right, the ones that fade.
Exactly. Port wine stains do not spontaneously involute or disappear on their own. They persist throughout a person's life. In fact, they can change over time, often starting pink and flat in infancy, then darkening to red or purple and potentially becoming thicker and raised later in adulthood. They are typically unilateral, meaning they tend to affect one side of the body.
Just one side, usually?
Usually, yes, though they can be bilateral. And while it's rare, there are acquired forms mentioned, maybe linked to trauma or other things. But honestly, for revision, the focus is overwhelmingly on the congenital type.
So the big takeaways are, born with it, it's blood vessels, it's permanent, won't just vanish.
Precisely. That's the core definition.
Okay, that covers what they are. Now, why do they happen? Let's talk etiology, the cause. What's the underlying issue here?
Well, the primary cause pointed to is genetic mutation. This happens during embryogenesis, when the baby is developing. It affects the way the blood vessels are forming in the skin.
Okay. And while the specific genes aren't sort of fully pinned down yet, it's understood to be related to how those vessels are constructed. Does it run in families?
It can, yeah. While many cases are sporadic, they just appear without any family history. They can also be inherited, typically in an autosomal dominant pattern.
Right. So if someone has a port wine stain, is there anything specific in their history or maybe lifestyle that might have caused it? Any modifiable risk factors?
The sources are quite clear on this. Aside from a positive family history playing a role in some cases, there are no known preventable risk factors.
Nothing you can do to avoid them, essentially.
Nothing like that. They are developmental. However, and this is absolutely critical to remember, they are associated with certain genetic syndromes. And that association itself is a risk factor for, well, more widespread problems, depending on the location of the stain.
Okay. That's a perfect segue. Let's unpack how this abnormal blood vessel development actually manifests under the skin, the pathophysiology. What's going on structurally that causes that permanent color?
Right. Think of the blood vessels in the affected skin area. Instead of being normal, fine capillaries, they're described as abnormally proliferated and crucially dilated.
Dilated, so wider than normal?
Yes, much wider than they should be, and they stay that way permanently. This dilation means there's more blood held closer to the surface of the skin, which is why you see that persistent pink, red, or purple color. The sources mention a bit more detail, things like abnormal dilation of dermal capillaries and venules, and maybe a role for reduced vascular tone.
So they can't tighten up properly.
Kind of like that, yeah. Imagine the vessels have lost their ability to contract properly, perhaps due to issues with the tiny nerves around them. They're like permanently relaxed tubes just holding blood there. There's even mention of subtypes based on vessel depth and maybe growth factors like VEGF, but the core idea for revision is just dilated, persistent vessels near the skin surface.
Okay, that image of permanently dilated vessels really helps clarify it. So we know what they are, why they might form, but skin lesions can look similar, right? What else might look like a port wine stain? And more importantly for exams, what serious conditions are they commonly associated with? This differential diagnosis and associated diseases section feels really key.
Right, absolutely key. First, the differentials. You'd want to consider other vascular birthmarks like hemangiomas.
But they usually shrink, you said.
Exactly. They typically grow, then shrink, which is different. Also, pigmented birthmarks like cafe spots, they're brown, look different. And then you've got acquired things causing discoloration, like venous malformations, which usually feel different, maybe compressible.
Okay.
Now, on to the critical part. The associated syndromes. These are conditions where the port wine stain is basically a clue, a sign of underlying vascular issues elsewhere. And the location of the PWS is a major hint here.
Location matters a lot then.
Hugely. For example, if you see a port wine stain involving the eyelids, especially the upper eyelid, this strongly suggests an association with glaucoma.
Glaucoma. Okay, serious eye pressure issues.
Yes, a serious risk that needs careful checking. Then the big one, the most commonly tested association, is Sturge-Weber syndrome. This is where you have a facial port wine stain, particularly one following the distribution of the ophthalmic division of the trigeminal nerve. So think forehead and upper eyelid.
That specific area.
Yes. And it's associated with vascular malformations in the eye, causing glaucoma potentially, or the brain. This can lead to significant problems: epilepsy, weakness down one side, hemiplegia, learning difficulties. If you see a PWS on the face, especially near the eye, think Sturge-Weber.
Right. That's a massive red flag.
Definitely. Other associations mentioned, perhaps less common, but still important. Cobb syndrome, that's a PWS on the skin over the spine, linked to vascular malformations in the spinal cord coverings. Then Klippel-Trenaunay syndrome, PWS usually on a limb combined with varicose veins and overgrowth hypertrophy of that limb, can lead to bleeding or ulceration. Parkes-Weber syndrome is similar to Klippel-Trenaunay, but adds an arteriovenous malformation, an AVM.
An AVM.
And finally, Wyburn-Mason syndrome involves facial PWS along with a unilateral AVM affecting the retina and the optic nerves inside the skull.
Wow. Okay. That's quite a list of potential associations. It really hammers home why the location is so important. It sounds like an MSRA question could easily give you, say, a baby with a stain on their left forehead and eyelid and ask what you'd be most worried about.
Absolutely. And the answer there would point towards Sturge-Weber and screening for glaucoma. That link between eyelid PWS and glaucoma is golden.
Definitely one to remember.
Mm.
Okay, shifting gears slightly, how common are these? What's the epidemiology like?
They are relatively common, actually, affecting about 0.3% to 0.5% of newborns, so maybe 1 in 200 to 1 in 300 babies. The exact UK prevalence isn't known, but that gives a good ballpark.
And any difference based on sex or ethnicity?
No, according to the sources, there's no significant gender or racial difference. Pretty evenly distributed.
Okay, so what do they actually look like when you encounter one in clinic, and where do they usually pop up? Clinical features time.
Right. As we said, they start as flat patches. Initially, maybe quite pale pink, but typically well-demarcated clear borders. Size and shape vary massively. Location-wise, most commonly on the head and neck. That's about 65% of cases according to the source material. Usually unilateral, but can be bilateral.
And the changes over time. You mentioned they don't disappear.
Exactly. The natural history is key. It's there for life. It doesn't fade. Over time, it changes. Starts flat and pink in infancy, usually becomes redder in early adulthood, then often deepens to a purple color by middle age. And importantly, particularly with facial lesions, they can become thicker in adulthood, develop raised areas, sometimes described as having a cobblestone appearance or contour.
Cobblestone, like bumpy.
Yeah, exactly. Bumpy, thickened. This can happen in maybe up to 2/3 of facial PWS cases later in life. Oh, and sometimes little red lumps called pyogenic granulomas can pop up within the stain, especially if it involves the inside of the mouth.
Right, that progression from flat pink to potentially raised, bumpy purple over a lifetime is a really distinct feature. I can definitely see an exam question describing an older patient's thickened facial PWS and asking about that change.
Yes, understanding that natural evolution is important. It reflects changes in those dilated vessels over decades.
Okay, so how do we actually diagnose them? And, crucially, when do we need to order scans or other tests? Let's talk investigations.
For the vast majority, the diagnosis is purely clinical. You see the characteristic appearance, note it was present at birth, usually that's enough.
Just based on looking at it?
Pretty much. Additional investigations come in when you suspect one of those associated syndromes or potential complications. So if you're worried about Sturge-Weber syndrome because of the location, an MRI of the brain is the main test. Although the sources do caution that MRI results in very young infants might be misleading sometimes.
Okay, so MRI for suspected Sturge-Weber with a note of caution in babies. What about other imaging?
Well, newer things like photoacoustic imaging are mentioned, but the key takeaway for revision is this. There's no consensus or general recommendation for routine brain imaging just for an isolated PWS if there are no signs pointing to a syndrome.
So you don't just scan everyone with a PWS.
No, not unless there's a specific clinical suspicion. However, and this is the big exception we keep coming back to, if the port wine stain involves the eyelids, especially the upper one.
Check the eyes.
Absolutely. Regular ophthalmic checks are essential in the first 3 years of life to screen for glaucoma. That's non-negotiable in that scenario.
Okay, crystal clear. Diagnose clinically, investigate if you suspect a syndrome, but always check the eyes if the eyelid is involved.
Yeah.
Got it. Now, the really practical bit for revision, how are they managed? What do we do about them?
Management really has two main goals. First, improve the appearance of the birthmark, and second, address any associated complications, which usually stem from those syndromes we talked about. The primary treatment, the gold standard really, is pulse dye laser therapy, PDL.
PDL, how does that work?
It uses a specific wavelength of light that's strongly absorbed by hemoglobin, the red stuff in blood. This energy heats up and destroys those tiny, abnormal, dilated blood vessels. The clever part is it does this without causing significant damage or scarring to the surrounding skin, ideally.
So it's targeting the color by selectively zapping the blood vessels causing them.
Exactly. It zeroes in on those dilated vessels. Now, it usually takes multiple treatment sessions.
Not a one-and-done thing.
Definitely not. Multiple sessions, often months apart. And these might need anesthesia, especially for children. It's also noted that the best results are generally seen when treatment starts early, in infancy. But crucially, not everyone responds equally well, and achieving total clearance, making it disappear completely, is rare.
So the goal is usually fading it significantly.
Yes, significant lightening or fading is often the realistic goal. Other options mentioned include surgical excision for maybe smaller lesions that don't respond to laser, cosmetic camouflage, special makeup basically, and sometimes tattooing with skin-colored pigments. There's also ongoing research into combining PDL with other things to boost results. But the main message is, management aims to improve appearance, often involves early PDL, and requires multiple sessions.
Right. What's the long-term picture then? The prognosis for someone with a port wine stain?
Generally speaking, if it's just an isolated port wine stain, no syndromes involved, it's medically harmless. It doesn't pose a significant risk to physical health itself.
That's reassuring from a purely medical standpoint.
Yeah.
But what about the visibility?
Yes, that's a critical point. While physically harmless in isolation, port wine stains can have a really substantial psychosocial impact.
Especially if they're on the face, I imagine.
Exactly. If they are large or on the face or another very visible area, it can significantly affect self-esteem, body image, quality of life. So the medical prognosis might be good for isolated cases, but the psychosocial aspect is really important to consider. And like we said, treatment response varies. Complete clearance isn't guaranteed. The lesion is permanent.
Okay. Lastly, let's quickly cover complications. What potential problems might someone face beyond the psychosocial impact?
Well, again, the port wine stain itself doesn't usually cause major complications. The main issues arise from those associated syndromes.
Right, the Sturge-Weber problems, for instance.
Exactly. The neurological issues, seizures, weakness, and definitely the eye problems like glaucoma that come with conditions like Sturge-Weber. Glaucoma risk is reiterated as a specific complication to watch for with large or deep facial stains, especially involving the eyelids.
And complications from the treatment itself.
Yes, those can happen. Laser treatment can cause hyperpigmentation, darkening of the skin. That's often common, but usually temporary. More rarely, you can get permanent hypopigmentation, lightening of the skin. Sometimes those pyogenic granulomas can form in treated areas, and occasionally patients get a type of skin irritation, eczematous dermatitis, though that usually responds to treatment.
Okay, I think that gives a really thorough run-through, hitting all the key points from the material. We've covered the definition, the causes, the appearance and changes, those critical associations, investigations, management, everything. Hopefully this deep dive really helps clarify the essentials for revision.
Definitely. And just to reiterate, remember those associations, particularly Sturge-Weber syndrome and that crucial link between eyelid involvement and glaucoma. Those are really high-yield points for exams like the MSRA.
Excellent. What stands out to you now after hearing all of that laid out? Is there a specific syndrome or maybe a treatment detail you want to revisit or connect with something else you're studying? Keep digging. For more free MSRA revision resources, you can visit freemsra.com. And for the full premium revision toolkit, head over to pastmsra.com. We'll catch you on the next Deep Dive.